I'm Dr. Chris Aiken.
I'm Dr. Greg Malsberg.
And I'm Kelly Newsom, a psychiatric NP.
And this is Carlat Psychiatry News, where we give you the biggest psychiatric updates for the month.
We used to think that bigger was better when it came to antidepressant dosing, but that was based on studies with tricyclics, some of which correlated tricyclic response to serum level. It hasn't held true for the newer generation of antidepressants after Prozac, and this new study puts another nail in that coffin. This study looked at the problem from a different angle. It's a network meta-analysis, which means that it assumes that the placebo arms in all of the 160 trials that it compared are similar. Now, in reality, we know that they are not. Placebo arms differ, but the results of this analysis still land in the same ballpark as prior analyses did, which is that the benefits of antidepressants plateau once you get beyond the lower dose range for depression. We're talking doses like 20 to 30 milligrams a day for fluoxetine, 60 milligrams a day for duloxetine, and around 30 milligrams for mirtazapine. The results are in line with an analysis that Dr. Rian Aziz published in the April 2022 edition of Carlat Psychiatry Report. The online article has optimal dose ranges for most antidepressants. There were 3 exceptions here, where the benefits continued to rise even into the higher dose range. Those are the tricyclics. In this analysis, they looked at amitriptyline and clomipramine, and the norepinephrine-based antidepressant reboxetine, which is available outside the US. The great unknown here is the MAOIs. No analysis of dose-response curves have looked into that class. MAOIs are reputed to have a dose-response curve where going higher brings better results, similar to the tricyclics, but that clinical lore is largely based on a case series from 1989 where they tested high-dose tranylcypromine in treatment-resistant depression. How high? We're talking 90 to 170 milligrams daily with an average of 112 milligrams a day. At that kind of dose range, you're going to need to check for orthostatic hypotension and watch for falls in the patient. The bottom line, unless it's a tricyclic or an MAOI or reboxetine, going beyond the lower dose range with antidepressants is likely to bring more side effects, things like insomnia, fatigue, tremor, sexual dysfunction, and apathy, even things that can look like depression, without moving the needle much on depression itself. But wait, haven't we all seen patients who got better, say when we moved fluoxetine to 80 milligrams a day? Yes, we've all seen the placebo effect in practice, and it is quite large.
Can probiotics make a difference in ADHD? 2 recent studies suggest they might, but the improvements are subtle. Researchers in Iran and Taiwan explored whether adding probiotics to ADHD medications could help reduce symptoms. Let's take a closer look at those 2 studies. In Iran, kids who took probiotics with their medication saw a 15% drop in ADHD symptoms after 4 weeks, but the benefit didn't last through the full 8-week study. The kids did, however, show better focus on auditory tasks than those on a placebo. Meanwhile, a 12-week placebo-controlled trial in Taiwan found that kids with ADHD had 20% faster reaction times and made fewer mistakes on attention tests when a probiotic was added to their methylphenidate. The researchers also found positive changes in their gut bacteria, which could be influencing brain function. Both studies pointed to some improvements in attention, but core ADHD symptoms like hyperactivity didn't budge much. How does this fit with what we know about ADHD? We covered the role of diet and ADHD in our October 2022 journal of the Carlat Psychiatry Report. The conclusion? That elimination diets and heart-healthy DASH diet can help reduce ADHD symptoms. Probiotics seem to tap into the same gut-brain connection. The idea is that a healthier gut microbiome can improve attention and behavior. Probiotics aren't about to replace ADHD medications, but they might offer a little extra help, especially for improving focus. Here's the bottom line. On the probiotic side, these trials build on earlier studies, showing cognitive benefits with probiotics in depression and other populations. On the other side, small trials like these are shaky ground to stand on. The results were not dramatic and point to a need for larger trials.
When I graduated from residency, the chairman, Rangakrishnan, gave me one piece of advice. Remember, he said, the placebo effect is often bigger than what you'll achieve with most of our medications. Look for ways to enhance it in your practice. That has always inspired me, but it's also left me with a lingering doubt that this new study helps to settle, at least a little. How do you tell if your patient is responding to the med or to the placebo? This study analyzed 90 trials comparing before and after results with the placebo arm only. Their aim was to find out which psychiatric disorders are most placebo responsive. Here's what they found. The disorders that are most responsive to placebo are major depression and generalized anxiety disorder. After that comes panic disorder, ADHD, PTSD, social anxiety disorder, and bipolar mania. Those with the lowest response to placebo were OCD and schizophrenia. Those high placebo responses in depression and GAD are even higher for children. A lot of people were surprised to see the bipolar mania in the middle of the list along with PTSD and social anxiety. Well, mania does respond to a stable, regular environment with regular activities, darkness at night and light in the morning, and most mania studies were done in the hospital where that's part of the treatment. Besides the fact that many of those mania studies allowed PRN medications like benzodiazepines in the placebo arm. Otherwise, giving manic patients nothing but a sugar pill for a month is ethically questionable. In practice, most patients are responding not just to the placebo or just to the med, but to some mixture of the two, and this study gives us an idea of which of those mixtures has the upper hand. Remember, the placebo is not just false hopes about a sugar pill. It is the natural course of illness and includes regression toward the mean. That's a fancy way of saying that patients tend to come in for help when they are at their worst and likely to get better from there no matter what we do. The placebo also builds in the therapeutic relationship and the patient's own resiliency, such as when an anxious patient feels a little safer now that they're in treatment and ventures into braver acts that they would have otherwise avoided on their own. All of this reminds me of an NIH study that David Mintz shared with us last June. This was a study of antidepressants and depression, but instead of looking at which patients got better, they looked at which providers got their patients better. The results were striking. Highly effective providers got their patients better regardless of whether they were on placebo or antidepressant, while other providers had poor results even with the medication. The highly effective doctors got better results with placebo than did the doctors at the bottom group with the antidepressant. Dr. Mintz is a psychiatrist at Austin Riggs. You can read his full interview on how to enhance the placebo response in the June 2024 edition of the Carlat Psychiatry Report.
Have patients struggling with anxiety and a long wait list for therapy? There's good news. The FDA just approved Daylight RX, an app that delivers CBT for generalized anxiety disorder. It showed big results in 2 clinical trials, reducing anxiety symptoms to levels similar to or better than some anxiety medications. In a trial with 256 patients, Daylight RX cut anxiety symptoms by a large margin. Patients using the app had an effect size of 1.08. For comparison, SSRIs typically show effect sizes of 0.3 to 0.7. Here's what the trial found. 71% of patients using Daylight RX saw their anxiety levels drop to non-clinical ranges within 10 weeks. That's compared to 33% in a control group who didn't use the app and were assigned to a waitlist control. Essentially, twice as many patients reached a point where anxiety was no longer a serious problem. The company submitted another trial to the FDA with similar results but a stronger design. This one, the GATE trial, compared the app to a psychoeducation program about anxiety. And once again, the app brought twice as many patients to remission as the control, 70% versus 35%. The point here is that it was compared to an active program, a much more difficult race to win than comparison to a waitlist. Unlike other mental health apps, DaylightRx was designed specifically for anxiety with short interactive sessions that easily fit into daily life. It performed much better than Rejoin, a recently approved CBT app for depression that actually failed in its trial. So why did a CBT app work better for anxiety than depression? I don't know, but it reminds me that generalized anxiety disorder was first conceived of in 1980. It was seen as a disorder for which psychotherapy was the answer. Maybe we're going back to that. Or maybe it's just harder for patients with depression to find the motivation to stick with the app on their own. Not everyone can afford therapy or add it into their busy schedule. With DaylightRx, your patients can start effective treatment right on their smartphones. It's easy to use, proven to reduce anxiety, and now it's FDA approved.
No one really knows what to do when patients with ADHD use marijuana, and this study aimed to give us some guidance. They randomized a small group, just 28 patients with ADHD and also cannabis use disorder, to either take placebo or high-dose amphetamine. By high dose, I mean 80 milligrams a day of Adderall XR. They tested these for 3 months and then looked at whether the stimulant improved the ADHD symptoms and whether it helped the patients come off the weed. Despite the high dose, the amphetamine made no difference in ADHD symptoms or cannabis use. Now, there's some problems here. This study was small and it was also hindered by a high dropout rate. But its message is the same as an earlier and much larger trial of methylphenidate in 303 teens. Again, no difference in ADHD symptoms or cannabis use with the stimulant treatment. 2 trials of atomoxetine, Strattera, also arrived at the same dismal conclusion. Now, the data here is not definitive enough to say that ADHD medications cannot help when marijuana is on board, and they don't tell us if there's any kind of threshold effect, like how much marijuana do you need to use to actually block the benefits of a stimulant. But we can at least say there is no evidence that ADHD meds help people who are using marijuana. And pairing that with other studies that show marijuana interferes with executive functioning and causes symptoms of ADHD, we have reason to believe that there is a real interaction, a real problem going on here. Whether or not you decide to prescribe ADHD meds, stimulants or non-stimulants, in people who are using marijuana is going to depend on the patient and your own risk tolerance. But you do need to inform these patients that the treatment is not likely to work as long as they are smoking. And that may be news to them, because we know from surveys that most patients believe marijuana helps their ADHD in spite of these other controlled trials showing that marijuana makes ADHD symptoms worse.
If you're treating patients with binge eating disorder, here's something that can make a difference. A new 12-week study of 93 patients from Iran found that combining lisdexamfetamine, Vyvanse, with topiramate led to better results than lisdexamfetamine alone. Patients who took both medications had greater improvements in their binge eating, lost more weight, and showed healthier metabolic profiles. Here's what stood out from the study. Weight loss was more impressive with the combination. Patients dropped about 5.5 BMI points, compared to just 3.4 points with lisdexamfetamine alone. Metabolic health improved with bigger reductions in triglycerides and LDL cholesterol in the combo group. And interestingly, the combo also came with fewer side effects. Patients had less insomnia and paresthesia, which were more common with lisdexamfetamine alone. Both groups saw fewer binge eating episodes, but those in the combo had better all-around results, especially when it came to weight loss and improving metabolic markers. As highlighted in the November 2023 issue of the Carlat Psychiatry report, many patients with binge eating disorder don't bring up their binge eating directly, often focusing on other psychiatric symptoms. But tackling the binge eating disorder symptoms head on can really improve overall treatment outcomes. While lisdexamfetamine is the only FDA-approved medication for binge eating disorder, this study suggests that adding topiramate, typically used off-label for impulse control, makes a difference. It not only boosts effectiveness, but also reduces some of the side effects that can make lisdexamfetamine harder to tolerate.
I've heard a few complaints about antidepressants from psychiatrists and from patients. They tend to be things like this: that antidepressants don't address the underlying pathophysiology of the disease, that they have too many side effects, particularly sexual side effects, or that antidepressants just aren't powerful enough with only small differences from placebo. So what if we had a treatment that addresses the underlying cause, has few side effects, and a big effect size? You'd think we'd all be using it, but we're not. That's Lightbox in seasonal affective disorder. The status of light therapy did start to shift about 20 years ago when the American Journal of Psychiatry concluded that it has a large effect size in both winter and non-winter depression, around 0.8 to 0.9, which is much larger than the 0.3 to 0.4 range we see for SSRIs in their effect size. That paper was written by psychiatrists with no skin in the game. They were not light therapy researchers, and many of them, like Charlie Nemiroff, were heavily funded by the pharmaceutical industry. As far as side effects, outside of headaches and eye strain, light therapy is pretty well tolerated and even improves sexual dysfunction, possibly by raising testosterone levels in men, which tend to go down in the winter. So after 40 years of research and dozens of trials, I wasn't expecting to find much that is new when another controlled trial of light therapy rolled out from China this year. But this study didn't focus on depression outcomes. Instead, they looked at cognition and what was going on in the brain during light therapy. They randomized 88 patients with mild depression to either Lightbox or, as a sham placebo, a dim light box that wasn't powerful enough to treat anything. At the end of the trial, those who used the real Lightbox for 30 minutes in the morning for these 2 months were less depressed, as expected, and they also had better attention and vigilance. On fMRI, those two cognitive benefits correlated with improved connection between the right cerebellar lobule 9 and the left temporal region. That sounds promising, and it's in line with earlier studies of light therapy in dementia and traumatic brain injury, where it also improved cognition. But I've got to dampen the enthusiasm here. Whenever you see a study of cognition, check whether they corrected the results for tests of multiple measures. Cognitive tests usually have dozens of measures, which means that we're likely to see some random bits of improvement or worsening here and there just by chance alone. And these results did not pass that higher level test of multiple measures. But something else did stand out to me in this study. They found that the light therapy reduced activity in the default mode network. That default mode is the center of ruminative thinking, rumination, the vicious cycle of brooding and negative self-talk that we see in depression. And for many patients with depression, ruminative thinking is their main complaint, but we don't know much about what improves it. So TMS, transcranial magnetic stimulation, has some positive data, and this is encouraging on the biological front with light therapy, but I'd also like to see data with light therapy to see if this biological finding actually makes a clinical difference in ruminative thinking. Meanwhile, if you're interested in rumination, there is a new type of CBT, rumination-focused CBT, that addresses this symptoms, and you can learn how to use it in our interview with the founder of this therapy, Edward Watkins, way back in the July 2018 issue of the Carlat Psychiatry report. For light therapy, I have a step-by-step guide on how to use it on my website, chrisaikenmd.com/light therapy. And if you've followed those recommendations before, I have made some recent changes to the product recommendations for purchasing a Lightbox.